So this is a second part of the discussion we have started last week, that is critiquing a research paper. And today I'll do a practical example of that. Last time we did a bit of steps how to review the research and what is the importance of that. Today's paper is long-term outcomes of randomized controlled trial of a single incision versus multi-port laparoscopic colectomy for colon cancer. Before I go into that, I will just summarize the last session. So we said that critiquing a research paper is an important skill and it helps in evaluation of available research and application of evidence-based medicine. But it requires a systematic approach, and we need to assess credibility, validity, and reliability of a paper. So the credible sources does not mean that the paper would be valid and reliable. And even if you have credibility, validity, and reliability, sometimes these papers may not be applied to the practice straight away. So steps of critical appraisal include making sense of the title first of all. So you look at the terminology. Is the topic of recent interest? Is the terminology not too wordy? And the topic is of specialist interest versus general interest. Then we assess the credibility by assessing its level on the Oxford hierarchy, the randomized controlled trials versus the cohort and other studies. Journals, impact factor, author, institute, publication date, funding, resources, and references itself, which has been given in the paper. So they should be recent, balanced, and from the good journals. Then we read the abstract. It should give a general idea of the article. It should have a structure like background, methods, results, and conclusion. The authenticity of the abstract will be assessed during assessing the paper itself. It should be a true reflection of the article itself. Then you assess, step 4 is assess the validity and reliability. And what we said, reliability and validity, is that what they intended to measure, they have measured that, and if they keep on measuring again and again, they will produce the same result. So these are the two important characteristics of any research, especially the psychometric analysis. If you have valid and reliable paper, then there should be identification of the problem in the introduction phase, and that should be a real life problem. The aim is to provide solution to that problem. Should not be a publication for the sake of publication. The objectives, which are the measurable statements, they should be reflective of the aim. And when you have done the objectives, then you start preparing and designing a study, and that should actually include the participants which belong to that population which is under study. So if at any point you have the there is some bias, then probably your study is not going to be the reliable and valid. We've discussed that there could be sources of bias from the investigator, participants, statistician, literature, instruments, and extraneous variables. Now, instruments, if they've used any instrument to measure something, that should be a valid instrument proven in the literature previously. Once you have designed a study, included the patient, collected the data, then it should be analyzed by using an appropriate statistical methods, and these include different methods for the categorical and the numerical variables. We can't alternatively use these tests. There should be no error once you have done study, especially type 1 and type 2 errors. They should be avoided, and I think it's the rigorous design in the study and power measurement, so that you have a good sample size. Otherwise you will end up having a type 1 or type 2 errors. Results discussed, they should be appropriate. There should be no misinterpretation. The strengths mentioned in the study should be the true strength, and if you have a limitation, if they have discussed limitation, that should not affect the applicability of the study, because if these limitations are actually affecting in a way that you can't apply onto the population, then this study becomes invalid. And there may be some issues of the generalizability if they have a strict exclusion criteria. So there will be very, very specified population on which you can apply your results. Then you assess the overall structure, and we mentioned that the randomized control should have a consort, should be reported on consort guidelines, and similarly systematic reviews on the PRISMA guidelines. After all of these steps, then you assess the clinical applicability of the study, and it doesn't include only the external evidence, it also includes patient values and clinical expertise. So if you have a study which is very good study, is valid, but you don't have an expertise, probably you're not going to apply in the practice. And similarly, if the patient refuses any type of treatment, then it will not be applied in clinical practice. So let's start with the paper itself. The long-term outcomes of randomized controlled trial of a single incision versus multi-port laparoscopic colectomy for colon cancer. So it seems that the patient would be a colon cancer patients and they will undergo colectomy, and there are going to be two groups. One is the multi-port laparoscopic group and another one is single incision group. So this the terminology is simple. We can actually say that topic is of recent interest, and it is more of a specialist interest rather than the general interest. So it will be more suitable for the colorectal surgeons to review or critique this paper. Assessing the credibility. So I would say this paper is from level 1B because this is a single randomized controlled trial. Authors have already reported some studies based on the same research and also from the other research, and paper was published in the Annals of Surgery, which is good impact factor of 4. Publication date is very recent. It's this month in 2021, and there was no conflict of interest. References were good, and I have gone through the references. They are from American Journal of Surgery, British Journal of Surgery, Surgical Endoscopy, and they're quite recent from 2011 to 2020. So when I read the abstract, it looks like this publication is for the sake of publication. If you see the conclusion in the abstract, they said even though the result of the 5-year OS and RFs, I'm just reading what was written there. In this trial were exploratory and underpowered. There was no statistically significant difference between SILC and MPC arms. SILC may be an acceptable treatment option for the select patient with colon cancer. Now, because most of the time you have access only to the abstract and you don't have full length articles, so usually we try to avoid the abbreviation in the first time it comes into the article. But if I just read this one, probably are not going to make sense what is OS and what is RF. So these have not been explained in the abstract. So that is a bit of problem with that. And looking at into the conclusion, that is half-heartedly reported conclusion that there may be, there may not be. So it's not very persuasive conclusion. Assessing the validity and reliability, that was the most difficult step, and so I went through the introduction. So they have identified the problems that the oncological outcomes of single incision laparoscopic colectomy are not patient-based outcomes. Rather, these are the surrogate outcomes. I do agree with them because most of the studies they don't report the oncological outcomes like in the recurrence-free survival or overall survival. Rather, they look into the lymph nodes and the free margins. So I would say that the problem identified in the introduction was a real problem, and they also said that there is no randomized control to report long-term outcomes. Now, the aim was to report the long-term outcomes of minimal multi-port colectomy versus single incision laparoscopic colectomy by an RCT. Now, this is the aim of the study, although they mixed up the wording with aim and objectives. They were alternatively using these terms, although they are not. Objective of the study was to complete the 5-year recurrence-free survival, overall survival. To compare the 5-year recurrence-free survival, overall survival, and the recurrence patterns of SILC with those of the multi-port laparoscopic colectomy for colon cancer through RCT. So they were the reflective of aim, but not clearly defined. What I say is that we should have some operational definitions. That was not clearly documented. By operational definitions, I mean that if you say a recurrence-free survival, what do you mean by that, by numbers? And overall survival and recurrence pattern. So these terms have not been predefined. Because the recurrence could be anything. So it could be a radiological, histological, or even patient might have undergone surgery again. So we don't know what type of recurrence they're talking about. Study design was RCT. It was approved by the review board and it was registered. These are all the strengths. So they were appropriately designed. Now they have done a sampling, which is like participants were the true representative of the population under investigation with certain inclusion and exclusion criteria. That was a very strict criteria, inclusion and exclusion criteria. So when I went through the paper, I thought there will be some issues of generalizability, because you can't apply the that much strict criteria, you can't apply to the general population. So you can't say that every colon cancer patient having this can actually can have the results of the study applied to them. For randomization, they used a very good method, that was the computer generated, and they try to avoid any bias introduction there. Now, when I went through the sources of the bias, so participants were 200, and then they were randomized. This is their statement, that they had 200 participants which were randomized. But the study duration is about 2 to 3 years, and in cancer patients, we assume that they come into the pool, they get operated, and then they go out of the pool. So it's hard to imagine that how did they have a 200 patients pre-hand meeting the inclusion criteria and divided into the two different groups, and then being operated on 2 to 3 years time. So that didn't make sense to me. Then blinding was a double as compared to the triple, so statisticians knew that which patient has undergone what type of surgery, although this is very difficult to design triple blind studies. Surgeons were the same surgeons who were operating the multi-port versus a single incision, so there could be some sort of bias there on surgeons part. Then the most important thing was the definition of the conversion to multi-port from the single incision was if 2 or more additional ports are used. So they have actually defined that if you use a single port, extra port with the single port, then this is not a conversion. That is slightly, we can object that. We can question it. Now, they haven't mentioned that what type of instrument they use for the data collection. I would imagine that that would not be a big problem, because we are not making something subjective. Now, they have utilized a proper statistical methods. They use chi-square test for comparing the frequencies, and for numerical values they have used Whitney U test. 5 years survival, the recurrence-free survival and overall survival was compared by using Kaplan-Meier method, which is a very good recognized method. And similarly, hazard ratio was done by Cox proportional hazard model. So all these were the strength of the study, and especially they mentioned that they have done the intention to treat analysis, which is important, because you can have a different incidences if you exclude the patients who have left the follow-up, but they included these patients in the follow-up in the analysis as well. Now all the results were reported. Results have been reported honestly, through there may be some issues of interpretation. I will mention those, what are those issues. So here we go, the first table, and we can see that they have tried to make the two groups homogeneous by comparing their age and gender and BMIs. However, we have 9 cecums in the multi-port group, and we have 16 cecum cecal tumors in the SILK group, single incision group. So that could slightly affect, because we as surgeons are more anatomically oriented towards the right iliac fossa, and because of the our practice of doing appendicectomies, so that may be a bit of can cause a bit of bias. I'm not pretty sure I'm right or not. Coming towards the survival curve, so we can see that actually the SILK group has an inferior curve as compared to the MPC arm. And looking into the 95% confidence interval for the hazard ratio, you can see it's 1.39, which means 33% more hazards by doing the SILK group. And the confidence interval is very wide. It starts from 0.5 to 4.39. So it means that this the confidence which we can say that is very low. Interval is very long. So that puts a bit of question on the reliability of results they have produced. Similarly, if you look into the relapse-free survival, so hazard ratio is 1.37, and the interval is prolonged again. Although there is no statistically difference between the two groups, but silk is 88% survival, while the multiple port is 91%. Recurrence patterns, there's nothing much to compare between the two. So there are more reoccurrences on the silk group if you compare otherwise. So there are 7 in total, 5 from the liver and 2 from the lung. So there could be a question regarding, the safety of the procedure being done by a single incision. Interestingly, they have done the subgroup analysis, and in which only the females, they have 3/44, and the males, so this only favors the single incision in female, and similarly the stage 2 disease also favors the single incision, but rest of all of the subgroup, they favor the multiport colectomy. So even the subgroup analysis shows that is more favorable in case of multiport colectomy. So they have mentioned some strengths. They haven't mentioned any strength of the study, but the limitations they have reported, they can actually raise an applicability issue. Like exclusion criteria, they have themselves mentioned that is quite strict, and that would affect the generalizability of the study. And conclusion is a true representative, but not much endorsing, as I mentioned earlier. So we can put, actually, I'll go through the conclusion again, but actually we can put a different wording and we'll have a same conclusion. So assessing the overall structure of the research paper, I would say that its overall structure is compatible with the consort guidelines, and they reported according to that. Now coming to the clinical applicability, now we are living in an age where more of the surgery is going to be robotic rather than the single port. Development of clinical expertise, because it's difficult, the triangulation is difficult, and the safety is questionable. So we will not have clinical expertise in every center who can do with single port. And they have not reported, they might have reported in other studies, but they have not reported the operative time, which also affect the safety of the patient by prolonging the anesthesia time. And lastly, it would be acceptable to the patient because it will be more cosmetic, but putting everything together, I think it's not yet to be adopted straight away. So I would summarize that these RCT with issues in designing, conducting, analyzing and interpreting the results, assuming no type 1 and type 2 errors were there, they still have a limited applicability, and with minimal advantages of cosmesis, long-term outcomes are inferior, though not statistically significant, but may have clinically significant issues, especially reoccurrence rate and 5 years survival, recurrence-free survival. And generalizability may be an issue due to the difference in population they have done in Japan versus English. So I was discussing with Mr. Vitoni yesterday, and there may be a difference in the population group because straighter and shorter colons are easy as compared to floppy and long colons to be operated by single incision. Now, I mentioned that the trend is towards robotic surgery, so single incision surgery may be not of that interest. If I have to give an outcome to this paper, I would say it's not for changing practice, may have some academic interest, may need further studies, and will require training and resources. So the role of business interest cannot be ruled out from there. Thank you very much, and sorry for a bad start in the beginning. Yeah. 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 True. Yeah. Yeah. Based on the same results, I can put a conclusion in a different way. So I would say that although there is no statistically significant difference between the two groups, but the reported frequencies and the hazard ratios are higher for the single incision laparoscopic colectomy, and so it might not have a place. So it's the same results, but you can put it in a different way. Yeah, 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 yeah. I agree with that. Yeah. Any questions from the participants? Are you the only participant? Thank you very much. So there were two type of conversions. One was any group going into an open one. They had only one or two cases, and then there was conversion from single to multi-port by putting in additional two ports, and they have actually used in 9 or 12 patients they have used as extra port, but not considered that as a conversion. So that puts a really very big question on there. It was, yeah. I think the reported experience was more than 20-25. Just Rory, correct me if I'm wrong. 10, more than 10. Yeah, yeah. No, why I said surgeon bias, because you have designed a study, you want to report it, and then you can have a sort of bias if you're operating single, and then you want to actually complete it without a conversion. So there is always, if you're doing laparoscopically, you take it like a prestige to be completed. Although you can feel that there's a need to conversion, you won't. So this can induce some sort of bias there. No, no. Yeah, yeah. 10, yeah. Yeah, yeah. And in this particular study, they have not reported the other, important intraoperative complications or operative time. These have not been compared. They might have reported in other research, but not in this one. So we don't know exactly that what was the difference between the two. This is just on the focusing on the long-term outcomes. Yeah, it does. I can embark on the right side, but not left side is totally different anatomy for me. So yeah. Yes. So blinding is then nobody knows. It's like participants, surgeons, and then statisticians. If nobody knows that which group is assigned to what type of intervention, then this is triple blinded. And if the surgeon, if one party doesn't know, does know, then it's double blind, and then single and non-blinded. So you have every, on this, yeah, investigators, investigate. This is at the time of assigning, when they are assigning. So which group will be A or B group? So it's at the time of assignment. Yeah, yeah. Yeah. No, that they patients were definitely blinded, so they didn't know that what type of study they would be having. Yeah, most definitely. Well, I'd read different something different. Hmm. Yeah. Should we wind up then? Thank you, Roy. Thank you very much. See you next time. Bye.